Thankfully, these days, I don't pass out quite as often as I used to. It does still happen from time to time. And my family, because so many of us share these conditions, recognize it very well. We recognize it in our children. We know what to do about it, and we know how to manage it.
Welcome back to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic-trained expert in Ehlers-Danlos Syndromes. Today, we're going to be talking about lipedema. I'm so excited to talk about this because this is something that is taught even less in medical school than connective tissue disorders like the Ehlers-Danlos Syndromes. Our guests today are two people from the Lipedema Foundation. We are going to be speaking with Cassie Grosvenor, who is an MBA and project manager at the Lipedema Foundation. She lives with lipedema, Mast Cell Activation Syndrome, including hereditary alpha tryptasemia, POTS, and hypermobility. Drawing on both her professional background and lived experience, she is passionate about amplifying the patient voice, raising awareness of lipedema, and advancing understanding of its overlap with related conditions. Dr. Jessie Cochrane is VP of Research at the Lipedema Foundation. After earning her BS from MIT and her PhD from Yale University, she became a research fellow at Mass General Hospital and Harvard Medical School, investigating epigenetics and chromatin remodeling. Jessie is committed to advancing the science and nurturing the research community needed to uncover the pathophysiology and etiology of lipedema. This podcast is for education only and is not a substitute for personalized medical advice. Stay to the end for our hypermobility hack. Here we go. I'm super excited to tell you about the Bendy Bodies boutique. I am so proud of our fierce styles and flexible designs. These are created by hypermobile artists for hypermobile shoppers. There are so many fun items from clothing, accessories, home goods, and my favorite are the bags. I especially love the Weekender tote with one of the EDS Tough designs. Whether you're shopping for yourself or someone you love, there's so many options to choose from. A portion of the proceeds goes to support EDS nonprofit organizations. For more information, please visit bendybodiesboutique.com. Well, I'm so excited to be here today with Cassie Grosvenor and Jessie Cochrane. Thank you so much for coming to chat with me today about lipedema and the Lipedema Foundation. It is such an honor to have you both here.
Thank you. It's great to be here.
Such an honor to be here. Thank you.
Yes, of course. Lipedema, we know, is common and it's so under-recognized, which, wow, this is sounding familiar, right? Common and under-recognized and overlapping with other conditions that we talk about on Bendy Bodies a lot. Hypermobility disorders, connective tissue disorders like Ehlers-Danlos Syndromes. And we have talked about this before in episode 104 with Dr. Karen Herbst, which we will link in the show notes. I want people to definitely check out that episode as well. And today we're going to be talking about bridging lived experience and research. And I want to start with you, Cassie. Can you, for listeners who might not be aware of what lipedema is, can you tell them about lipedema? What should they know?
Yeah, absolutely. So lipedema is a chronic medical condition that is characterized by excess adipose tissue that primarily appears on the lower body, usually around the legs, the upper legs, the hips, and the buttocks, but it can also be on the arms. It can occur on the abdomen. It can occur lower on the legs. And it is very different from obesity and lymphedema, two conditions which it is frequently misdiagnosed as. But it does cause that symmetric buildup of fat tissue that can become quite painful and quite debilitating for those that suffer with that.
Okay. And Jessie, from a research perspective, how are we actually defining and classifying lipedema?
I mean, unfortunately, I think with a lot of these diseases, lipedema is a clinical diagnosis. There are no biomarkers. It's sort of based on expert clinicians diagnosing. And it's sort of defined by this, as Cassie was saying, sort of this symmetric but disproportionate accumulation of adipose or subcutaneous fat. So often on the lower legs, often on the legs and the hips and the lower legs, and it often spares the hands and the feet. And it comes with pain and tenderness in the adipose. Those are the big things. And then also the specific lipedema fat tends to be resistant to like diet and exercise, traditional diet and exercise. And so I think, as we learn more, the definition is still evolving, and we are working on some sort of more specific biomarkers and other ways to define it for research and for clinicians.
Yeah, it's like the quandary that we have with hypermobile EDS and HSD without having a biomarker and being clinical diagnoses. It's very, very challenging. And then you have people who get the clinical diagnosis, but they go to somebody else and that person might say, well, I don't think you have that. And it's very, very frustrating. We definitely need biomarkers for these conditions.
Yeah, I don't know if this is true for EDS, but for us, the different there's different definitions in different countries, right? Like it's not even sort of universally clinically diagnosed, so it's very complicated.
Yeah, I would definitely say that that's true. Hypermobile EDS, we have the 2017 criteria, and now we have the road to 2026. So that criteria is supposed to be coming out the end of this year. But at the same time, even within the US, there is definitely a vast difference in how people are assessing and diagnosing these conditions. So it's really frustrating. And I feel like goes both directions where there's people who will go in to see somebody and they don't go through the criteria at all. And then other people where they're sticking by it so strictly. It's like, well, you used to be hypermobile, but you're not anymore. Therefore, you can't have hypermobile EDS. And I don't agree with that. So yeah, it's really hard. So Cassie, if lipedema affects so many women, why is it still underrecognized and underdiagnosed? Of course, we hit on one thing, the lack of a biomarker. But what else?
Yeah, I think there are actually several things that are at play here. And I think very similar with hypermobility disorders, the amount of knowledge that practitioners receive in medical school about these conditions is non-existent. I've seen the write-up on the type of education that you typically would see for Ehlers-Danlos. It's basically a paragraph. In most medical school curriculums, you're not even going to get a paragraph about lipedema, and even lymphatic disorders in general are brushed over with a few sentences. And so I think that is one problem that is really causing it to be underrecognized. Secondly, I think we have seen this across the board with diseases that tend to affect women more than men. Women are often defined as, having things that are in their head or being a hypochondriac or highlighting things in their health that aren't taken seriously. And third of all, I would say just because lipedema is so often confused with either obesity or lymphedema, both of which may co-occur, it is not the same condition. And so I think those are probably some of the biggest factors that are influencing why it is still so unrecognized. At the same time, awareness is really growing, and we are very happy about that. Back in March of 2026, the artist Doja Cat recorded a TikTok and said, I think I have this thing called lipedema. And it was wonderful because it actually increased a lot of knowledge in just public recognition. We need that public recognition to go away from patients that are self-diagnosing and actually get into the hands of practitioners. And, that follows through to insurance companies and to ICD-10 code assignment and all of these things. There's a lot of factors that are really causing it to be so underrecognized, while it really truly is not that uncommon for women.
Yeah, it's amazing what happens when somebody with that kind of a platform, right, uses their platform in a helpful way like that. So I feel bad for them that they have the condition, but at the same time, like it's good to help that would help raise awareness. And I have to say, so I graduated from medical school a long time ago, quite a long time ago. I literally learned nothing about lipedema whatsoever. And I remember the first few times that I saw the word, I thought people were referring to lymphedema, but writing it incorrectly. I thought they were just calling it the wrong thing. But I kept having more and more people say, I want you to cover this topic on the podcast. And then Dr. Herbst's name kept coming up over and over again. And so I researched her, and I was like, yes, this is a topic that we do need to cover. This is something that overlaps a lot. It's super relevant, super important. And so I'm so glad we're having this conversation. And Speaking of ICD-10 codes, Jesse, do you know, are there plans in the works for there to be an ICD-10 code for lipedema? And also, what are the biggest gaps in awareness amongst clinicians and researchers, would you say?
Casey covered a lot of the big gaps. There are plans for an ICD-10 code. I think that's been ongoing for years now. It's been presented in front of whatever board it is that makes these decisions. And I think several times, and we've made revisions. And I think that it's just still, they're still working on it. I mean, it would definitely help with everything if there was a way to track it accurately in medical records. I think the only other thing I would add to what Casey said about sort of the gaps, and I mean, one of the biggest gaps is obviously, as we've discussed, is sort of even just knowledge and recognition of the condition. And the other thing I think is funding. For a disease that does affect so many women, the funding pool is really small. And so I think that that's the other big problem for clinicians and for researchers is like people aren't, there's no impetus to do the research because there's no way to get grants to do the research. And so it's really, yeah. And I think until more research is done, there's always going to be this gap. And I mean, science in the country at the moment is in a pretty sad state. So it's sort of all cyclical and reinforcing on each other, I think.
So, can you give me an idea of the scope of the problem, Jesse? And also, is this something that exists on a continuum or on a spectrum? Like some people have, kind of a mild case of it, and some people have a severe case. Or do you have any idea about that?
Yeah, I mean, so we don't have good prevalence numbers, and I mean, this is partly due to lack of ICD-10 codes. And so, the data really range in different studies from sort of like saying between 1% and 10% of women suffer from lipedema, which is like huge. I mean, even if it's at the low end, that's still a huge number of people that would have this condition. And the way lipedema is traditionally considered is in stages. So there's stage 1, 2, and 3, and stage 4 of lipedema. So it's not clear if it's progressive. That's still sort of a unknown in the field. But there certainly are different symptoms that are associated with the different stages, and they're clinically defined again. So depending on, I think, the amount of disproportion, the amount of pain, the texture and feeling of the adipose that exists, these are the different ways that the disease is staged. But again, things like pain are not necessarily correlated with stage. And so the symptomatic expression of lipedema and the way that the person's body feels, that's a totally different question to sort of, but there is a spectrum. So yes, there is definitely a spectrum. But we're still learning a lot every day. So
Yeah, and pain is an experience. Pain is pain. Pain is what you're experiencing, and nobody knows what pain you're experiencing except for you. And we know that the amount of quote damage in your body versus the pain that you experience is not necessarily perfectly correlated in anything. So I don't know why it would be perfectly correlated in lipedema, because that would be a unique setting there. But yeah, people can have a lot of things going on in their body and not have as much pain, and other people have a ton of pain without as many objective findings. So that's obviously very, very frustrating for a lot of people.
And I think that like with a condition like lipedema, which is sort of chronic pain, some people can become somewhat inured to it, right? And so they're not necessarily able to say, oh, this is very painful, despite the fact that like fundamentally it probably is. They just aren't necessarily paying attention to that pain.
Yeah. And there's the like everyday pain, and then there's the like
Flaring.
different. Yeah, most definitely. Speaking of pain, Cassie, what are the most common signs and symptoms that people should be looking for?
Absolutely. I was really struck recently when I was sitting in UVA's Ehlers-Danlos Research Symposium at how many symptoms women with lipedema are experiencing that are also in hypermobility spectrum disorder. So I will name just a few of those. I think one of the first symptoms, even obvious at at the time of puberty, and sometimes even as early as a child being a toddler, is visibly seeing the shape of their legs. And so with lipedema, as with every disorder, it can vary widely between patients, but there's kind of two physical appearances. The first being a very pear-shaped body, and the second being more of a columnar, like almost like a tree trunk leg. Some of those things become visually, you're able to observe them prior to the patient even reporting any symptoms. And the other symptoms that you'll start to notice, again, overlap with hypermobility, very easy bruising. You will generally, in a person with lipedema, not always experience pain, particularly if that tissue is pressed on. So in the areas where lipedema grows, typically on the legs, sometimes arms and other areas, when you palpate that tissue, it is very painful. Patients will complain of their legs being very heavy, like walking around with concrete bricks. There will be a textural component very often felt under the skin, which may be as minor as, maybe like a beanie baby or rice feeling under the skin, all the way up to lobules and big nodules that are under the skin. And those are very painful when they are pressed on. Another thing that you will notice, and this is a differentiator between obesity and lipedema, is when you do have this excess buildup of fat, typically in a person with lipedema, you are going to see very normal sized hands and feet, and you will have a fat pattern that kind of carries down to either where the ankle is or where the wrist is, sometimes even the elbow. And it's almost like a line of demarcation where that fat abruptly stops and then the hands and the feet are spared. So those are, I think, just a few of those things that you will notice, and that is why it is so important for the clinician to talk to the patient about their history and what they've observed. I would say the other kind of leading thing to pay attention to is if you are minding the foods that you're eating and you are exercising and moving your body, and that excess fat seems very resistant to weight loss measures that would work for other people, like caloric restriction or a lot of cardio, for example, then you may be experiencing lipedema because those fat cells are typically very resistant to those measures compared with somebody with just regular standard fat.
So I made several notes as you were talking because for one thing I thought of was, okay, when you talked about the leg heaviness, that's tricky because that can also be related to pelvic congestion syndrome and or May-Thurner syndrome, right? So that's one thing. The other thing that I'm thinking is it's painful to palpation and differentiating that from the pain with palpation and light touch with fibromyalgia.
Yeah. Yes.
Or central sensitization. So like you said, it becomes tricky because there's a lot of overlap in presentations.
You're absolutely right. And I cannot tell you and I'm not going by data and science, I'm going just by the hundreds of patients that I engage with on a fairly regular basis. How many patients were actually diagnosed with fibromyalgia because the doctor is like, I don't know what's going on with you, so I'm just going to put this diagnosis on you. And then later on in life, they realized they actually had lipedema. And you've mentioned a few of these other conditions. In my short 5 years of experience with lipedema, I have never once met a woman who had lipedema only and not several other comorbid conditions. The ones that you mentioned are ones that I see pop up very often.
Yeah, and it's important because if you don't have the right diagnosis, then you're not going to be looking at the right treatments. And if you don't have the right diagnosis and the right, I know I said ICD-10 code, but I probably should have said ICD-13 code or something because probably by the time we actually get a code, we're probably going to be a few, variants down the road, unfortunately. But having the right diagnosis is critically important in order to have the right treatment and for tracking purposes as well, right? So this question could be for either of you. You two can decide who's going to answer this one. But I feel like it's really important to distinguish between lipedema and cellulite because I feel like that's something that is still, even in my mind, like a little bit confusing. Can you explain the difference there?
Jesse, I'm happy to take a stab at that and have you add on. Fantastic question, first of all. It is also something that we have recently blogged about on the Lipedema Foundation website. Cellulite typically is more of just an appearance without symptoms, whereas lipedema typically has a number of symptoms associated with it. And that's where that clinical exam becomes so important. So if you have someone that just, has a little bit of that dimpling and that texture in their skin, but they're not reporting that their legs are really heavy and they're finding it difficult to walk, and they are able to lose weight through traditional methods, including dietary changes and exercise. Those are typically going to be your more cosmetic instances. And they're probably not going to have things like accompanying brain fog and fatigue and all of these things. That is, I would say, probably some of the differentiation. That's where a clinical exam just becomes so important for the clinician to actually palpate that tissue. And as it progresses, that texture does change under the skin, whereas cellulite just kind of doesn't change a lot over time. It's typically just something that is there visually, but it's not impacting the person's mobility. It might bother them just in terms of their appearance, but it is not physically causing painful symptoms in their body. Jessie, anything you would add to that?
I would just say that also we know that lipedema tissue tends to be more prone to bruising. And I think that also is probably distinguishing from cellulite.
That's very helpful. And any other objective criteria or validated diagnostic tools or anything else, Jessie, that clinicians should be looking for when they're doing their exam?
So we are trying to develop some standardization of tools for research purposes so that we can collect all the data and hopefully start to develop some of these clinical tools, but at the moment, like objective diagnostic tools. But at the moment, nothing really exists. There's lots of work going in also to looking at, because we do know that lipedema leads to this disproportion. It feels like probably in imaging data, there might be good information that we should be able to extract and use that as a diagnostic tool. And this is all ongoing research, is to understand, what data exists already, and can we use any of that to extract measures. But at the moment, no. At the moment, it is all the clinical diagnosis by an expert clinician.
I would layer on to what Jessie said. There are definitely researchers that are doing things with MRI and ultrasound that are starting to note some of these changes, but those are not typically going to be resources available in nearly any clinic. We do have on lipedema.org a clinician's guide to lipedema that literally can walk any clinician through what questions to ask about the patient's history, what physical examination things would you do, either through visual inspection or palpating that tissue, even doing the stimmer test to see is there comorbid lymphedema that is occurring with that. And so as of right now, that clinical diagnosis, very similar, I think, to what you've seen in hypermobile EDS. That clinical examination, actually talking to the patient and visualizing what is happening in their body is our best test right now.
And for listeners who are not familiar, can you tell us about the Stimmer's test?
So that I am not a clinician, so I am describing this as a patient, but essentially there is a joint that toward the toes, and I won't reach down there to grab it, but essentially there is a way that the skin is pinched, and watching how the skin responds, how quickly it retracts or kind of goes back flat. That is a way that they can differentiate between lipedema and lymphedema. But again, to confuse things, these conditions can co-occur. And so that's where a clinician having the knowledge of both conditions and being able to differentiate if it is one condition, the other condition, or both conditions on top of each other becomes important.
And Jessie, what are the ways that you see lipedema getting mislabeled in clinical practice? What are the big diagnostic pitfalls that you're seeing?
Yeah, so I am also not a clinician. I'm a PhD researcher, but from what I understand, and I think from what probably Casey's lived experiences, it's obesity, right? Like it's overlap. Lipedema and obesity are definitely overlapping conditions. They're distinct conditions, right? Obesity doesn't necessarily usually lead to this painful sensation in the adipose. While it might impact your mobility, it doesn't have, I don't believe that it leads to this feeling of the heaviness and like the real concrete legs that Casey describes. And then also, it doesn't respond well to exercise or caloric restriction. So, an obesity label isn't that helpful in treating lipedema. And then the other is lymphedema. And there is overlap, again, between lymphedema and lipedema, but the underlying biology is very different between the two. So, yeah, I think these are the ways that it gets mislabeled the most in clinical practice. I don't think we can emphasize enough how important it is to listen to the patient and really understand what's going on in that person's body.
And I know you said we don't have great prevalence data on lipedema, so there may not really be an answer to this question, Jesse, but what kind of overlap there is between lymphedema and lipedema? Like, are we talking, more than 50% of the time, or, any thoughts about that?
It's not more than 50% of the time. I think it's more on the order of 20% of the time, in at least in the studies that I can remember. But there is definitely overlap, but it's not complete.
I would add, we often do see that overlap occurring at the later stages. And it really underscores the importance of an earlier diagnosis before it has progressed into such a later stage. But lymphatic involvement, once the lymphatic system is truly involved, that is where you're going to start seeing lymphedema come into play. And we definitely see lymphedema can occur at any stage. So you could be a stage 1 patient without obesity and you could have lymphedema. So there is not a one size fits all. Once you progress to this stage, you are going to move into lymphedema. It is not a direct progression in that way at all. So properly diagnosing what the problem is and beginning treatments as early as possible is the best way to try to prevent that. But with patients that do have both conditions, so many of the therapies that are very beneficial for people with lymphedema also show a lot of positive benefit for people with lipedema. So having the proper CLT or certified lymphedema therapist on your care team is so important because they are absolutely going to recognize either or both conditions and recommend the proper treatment.
Okay, I love that. And we'll definitely get more into the second half about treatment because I'm sure people are dying to know, so what? What do you do about this? This is all great information, but what do I do about it? So before we take the break, I do want to ask, and maybe Jesse will have you start with this. What can you tell us about the current research showing the overlap between lipedema and connective tissue disorders like EDS and hypermobility spectrum disorders? It appears that there must be some shared biologic or genetic pathway. What do we know about that?
So I think the most interesting thing right now in the lipedema space is there's really a lot of emerging evidence that extracellular matrix and the connection between cells that is impacted in a lot of patients. So we see, interestingly, problems with some collagen processing proteins. We see problems with byproducts of the collagen processing proteins, metalloproteases, these things that are really impacting the way that the cells themselves interact. And I think that's similar to what's being seen in some of these hypermobility spectrum disorders. The way that the tissue is embedded in this extracellular matrix is really starting to impact our understanding of the disease. The other thing I would say is, there's the prevalence for both hypermobility disorders and lipedema is strongly towards the female population. So that really suggests I think for both conditions, that there may be some sort of hormonal signaling pathway that could be involved. I mean, I think that's another interesting aspect to think about. And both of these seem very complex, likely polygenic, probably not strictly single. We're not looking for single genes that are mutated and do seem to be, some genetic component because they do seem to be inherited. But still the underlying mechanism, I think, for at least for lipedema is still being explored and trying to be understood.
And that's definitely true for hypermobile EDS and HSD as well. Exactly what you just said, like most likely polygenetic, environmental influences. I mean, we haven't figured it out probably because it's really not that simple or straightforward. So there's a lot of factors involved. And now there's some fascinating research looking at proteins and differences in, levels of proteins in people with hypermobile EDS and HSD versus comparison populations, and looking at the immune system. And is this, I had Dr. Ann Maitland on the show recently, and we talked about the epithelial barrier hypothesis. And is it the assault on our epithelial barrier and the mast cells, and then they release mediators that degrade connective tissue? It's all connected, most likely. So the immune system and yeah.
Yeah, I mean, adipose in particular is like this crazy tissue that has immune cells, vasculature, like fat cells. It's all interconnected. It's very hard to pinpoint the exact, either the cause or or what is continuing the progression of the disease.
So that's really interesting because I don't know about other people, but I don't consider myself an expert by any means on fat cells. But so the fat cells do have an interaction with the immune system specifically?
Yes. Your adipose tissue is composed of a bunch of different kinds of cells, including immune cells. And that's one thing that we're looking at with lipedema is there's been some reports about different kinds of macrophages, which is a specific kind of immune cell that are present in lipedema tissue versus sort of lipedema fat tissue versus non-lipedema fat tissue. So in fact, there's some thought that one of the drivers might be these different immune cells that are resident in the different kinds of fat tissue.
This is so interesting. We are going to take a quick break. And when we come back, we are going to talk about Cassie's diagnostic journey. We're going to go into that a little bit. And we also are going to talk about, well, what can you do? Now we have this information. People might be thinking, oh my gosh, I wonder if this applies to me, but what should I do about it? So we're going to take a quick break and we will be right back. I think we all have an outfit that we keep reaching for over and over again. And that's how I feel about my Cozy Earth jogger set. It is so comfortable, so soft. It's made from viscose from bamboo, and it's lightweight and breathable, and it just gets better and better over time. This is the outfit that I reach for if I'm hanging out at home or out running errands. It's what I want to wear over and over again. And I also really love their clogs. They're super comfortable. They have a lightweight cushioned footbed, and you can just slip them on to run errands or hanging out around the house as well. I also love that Cozy Earth offers a 100-night sleep trial and 10-year warranty. I don't know any other company that does that. I don't know about you, but this is a really incredible way that Cozy Earth stands behind their products. This spring, give yourself the kind of comfort that lives with you all day, not just the moment that you get home. Head to CozyEarth.com and use my code BENDY for an exclusive 20% off. And if you get a post-purchase survey, mention that you heard about Cozy Earth right here on the Bendy Bodies podcast. Comfort lives here. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. We are back, and we are talking about lipedema today, and this is such an interesting conversation. And Cassie, I am so curious to know how your diagnostic journey went.
Oh, goodness. Do you have all day?
Yeah.
So I do have lipedema. I was diagnosed at age 40, about 5 years ago, but the path to that diagnosis was very long. So that path actually started, I think my first symptom was around age 3, and I fainted with no particular reason. And this was back in the early 80s. There was really never any reason given for why this toddler has just spontaneously passed out. And then that pattern continued, dramatically increasing throughout my entire childhood. And for a lot of reasons, it simply was never diagnosed. But I was finally diagnosed first with POTS in my early 20s. And that was the first time that we started to understand why I had this whole spectrum of things like constant dizziness, nauseousness, just passing out all the time. That was kind of the first sign. While I noticed from probably as young as I can remember that my legs were shaped differently from everyone else, it was never something that I dwelled on. It was never something that I mentioned. And so, we continue throughout my 20s, and I am having just a number of symptoms that are escalating across the board, allergic to everything, constantly being sick with nasal symptoms, with eye symptoms, stomach symptoms. The fainting continued as the POTS and autonomic dysfunction continued, and that pattern just continued and progressed. And I don't think there is a single body system that was not impacted by all of these things stacking up, and not one doctor recognized a pattern in any of this. There's no way I could have time on this webinar to talk about as many conditions I've had, but some of them included my vocal cords just stopped functioning properly. I started having extreme issues with speaking, with swallowing, things like that. They kept coming back to, "You're obese." It was one of the most frustrating paths to diagnosis I think I've ever had. But the tide started turning in 2018. And I owe all of this to my oldest sister, who shares all of these same conditions with me. She found an NIH trial that was looking at a mast cell activation disorder, specifically hereditary alpha tryptasemia. And she and her family went through that first. And then they expanded the trial to pull in a number of other symptomatic family members, myself included. And so in 2018, I received that research diagnosis of hereditary alpha tryptasemia. The following year, my sister went to a mast cell disorder conference. And while your listeners listening to the podcast won't be able to see it, there was a pamphlet called "What is Lipedema" sitting on the table at this conference. And my sister picked that up and started looking at the pictures. And she was like, "This is the legs of every woman in our family. What in the world? Why has no one ever seen this?" And so she brought that pamphlet home, talked to us about it. I would say for about a year, I was in denial. I'm like, I already have everything wrong with my body. People think I'm a hypochondriac. They think I'm falling apart. I don't want this. I'm not dealing with it. So it took me about a year of denial. And then I had a particularly traumatic just rupture under my skin of bruising. And I was like, something's got to give. I have to get to the bottom of this." So I finally accepted her recommendation, and I saw a certified lymphedema therapist. And she said, "Of course you have lipedema. Let's get you on the path to moving forward." So fast forward just a little bit beyond that, after my diagnosis, the Lipedema Foundation was at a conference that I attended. Again, didn't really know anything about the organization, but they had a live research event. And the diagnosing clinician at that event was none other than Dr. Karen Herbst. And when I went into the room to have my clinical exam, she was like, "Has anyone ever told you you're hypermobile?" And I was like, "No, no." And I'm like, I'm stiff. Like, I have a really hard time moving around. And when she told me to put my hands on the floor, and negative 2 seconds, my hands were flat on the floor without me even thinking about it. She's like, "Yeah, I think you're hypermobile." So the diagnoses have stacked over the years. And ironically, I have not been formally diagnosed with hypermobility to this day. I am awaiting formal diagnosis. I'm on a wait list with UVA's Ehlers-Danlos clinic as it happens. But the signs and symptoms are all there. I understand the hypermobility is at play, and it explains literally a lifetime of conditions across my entire body and answers so many questions. But I would not have realize that I had hypermobility until I got my lipedema diagnosis. And I suspect for many of your listeners, they may already be carrying a hypermobility diagnosis or MCAS or POTS, and they might not even realize when they think about their bodies that there is yet another condition that is kind of happening alongside all of this. And so I'm hoping for your listeners, if they recognize anything familiar about this, they will begin exploring this because it is treatable. And I look forward to sharing what you do about this condition.
And it's so interesting because you said that you have been diagnosed with hereditary alpha tryptasemia, so an extra copy of the alpha tryptase gene, which is generally associated with higher tryptase levels. And that in and of itself creates a picture that looks like POTS, MCAS, and hypermobile EDS or HSD, right? So I know that there's a lot of discussion in the literature, like, do you have all those different conditions, or does alpha tryptasemia cause a phenotype that looks like that? And the other tricky thing, as I discussed with Dr. Ann Maitland recently, is there are also people though that have the extra copy but don't have this picture. So it's also like incomplete penetrance is what she was referring to. So it's I feel like we learned so much, but at the same time, there's so much that we don't know, and it's so frustrating. And like you said, it's not that you want to accumulate more labels, but you want to know what are the right things that you should be doing in order to feel better. I'm curious to circle back because I feel like somebody's going to ask about this. When you mentioned that you were diagnosed with POTS in your 20s, but it sounds like you were continuing to have very poorly controlled POTS into your later 20s, early 30s, et cetera. Were you not treated for POTS?
Yeah, so I did start treatments that helped a lot with that. But ironically, it was once I started my conservative therapy for lipedema that my POTS symptoms improved dramatically because I started wearing medical compression. And suddenly I was not having syncope episodes quite as often. And certainly over time, I have learned to understand my triggers, and I have learned to recognize when it is coming on, and I know exactly what to do to fix it. So I would say that over my 20s and 30s, I actually got tremendously better at managing my POTS symptoms. I am on several medications that manage it and keep it mediated. So thankfully, these days, I don't pass out quite as often as I used to. It does still happen from time to time. And my family, because so many of us share these conditions, recognize it very well. We recognize it in our children. We know what to do about it, and we know how to manage it.
And I want to point out a very important point for people who may or may not have listened to other episodes of the podcast. And I want to make sure that we make a very important distinction here. You don't have to faint in order to have POTS. Lots of people with POTS don't.
Pre-syncope events.
Yes. So if you're thinking, gosh, I thought I had POTS, or maybe you don't have a diagnosis, but you don't have to faint in order to have POTS. A lot of people with POTS feel faint, but they don't faint. So let's talk about treatment for lipedema. What are the most common treatment goals and approaches?
So first of all, the goals are always there's a number of goals that we talk about specifically at lipedema.org/treatments. And those goals are to reduce the inflammation on the body, to decrease the adipose tissue, to reduce that fibrosis, which is where a lot of that pain is originating from, improving lymphatic flow, which is helpful whether you have lymphedema or not, prioritizing mental and emotional health because that's a huge component, and then promoting overall health. So those are kind of the main treatment goals. When we talk about specific treatments, on the website that I just mentioned, we probably have about 60 to 65 treatments that we have either learned through research and literature or through patient self-reports help manage the symptoms of lipedema. For my personal journey, I was diagnosed 5 years ago. I have been able to reverse the stage of lipedema. So when I was first diagnosed, I was between a stage 2 and 3. I had significant functional capacity problems. And today I am between a stage 1 and 2 and lead a very, very full life. And I would say that the treatments that have been the most beneficial for me in actually addressing the lipedema symptoms are, first of all, conservative therapy, of which I spend probably 1 to 2 hours every single day of my life. And when I say conservative therapy, I'm talking about wearing compression garments, using a pneumatic compression pump, using exercise that supports my body without stressing my joints or causing more pain. So for me, that's walking and swimming and doing low impact stretching and things like that. Changing the way that I eat to remove the majority of processed foods and sugars. So essentially, anti inflammatory eating, trying to remove those triggers that would cause inflammation. Those are probably some of the biggest ones. I am always very willing to mention that I do use GLP-1 medications. I have been on them since 2015. And after 11 years, I can say with certainty they have absolutely caused a lot of relief in my system. But interestingly enough, they didn't for the first 6 years I was on them because I had not been diagnosed with lipedema and I did not know how to treat the lipedema. So once I started layering in those therapies, the GLP-1 meds actually started benefiting my body. And then finally, and I will not discount this, I have had 5 lipedema removal surgeries. That is a very personal choice for anybody that has lipedema. And I would never recommend it until you have truly changed your lifestyle to incorporate the conservative therapies, the changes to your eating, the changes to your exercise routines. I don't think that surgery should ever just be taken as the first step for lipedema. And it is also not a cure. It is a reset that provides you a little bit of relief, but lipedema does not currently have a cure. I hope that changes one day in my lifetime. It does not have one today. So managing it is actually what you need to do to control those symptoms.
Well, I really appreciate you sharing so much detail about your own personal story here, because that is very helpful. Can you go back just a little bit and explain more when you were talking about a pump, like a pneumatic pump?
Absolutely. So a pneumatic compression pump is a device that you put your lower body into. The particular pump that I have actually comes right up to my rib line, and it uses sequential chambers of air kind of building up, and it helps push that lymphatic fluid and helps particularly for people that have swelling. And not everyone with lipedema does have swelling. Some do, some do not. I do. It's relatively minor, but the that pumping action helps push that lymph out of your lower body where you typically have, that swelling building up, and it pushes it so the lymphatic system can actually process that and get that waste out of your body. And that was something that required a prescription by a certified lipedema therapist in conjunction with my primary care doctor. It is something that it really replaces the need for a person to have to go to constant manual lymphatic drainage therapy. I didn't mention that when I mentioned the treatments earlier, but that is something that has been extremely beneficial and is for many people with lipedema. But essentially, the pump brings that manual lymphatic drainage therapy into your home, which particularly for a patient whose mobility has already been severely impacted, their therapies can only be as helpful as they have the ability to carry them out. So by having that lymphatic pump in my home, I'm able to do my therapy 7 days a week rather than taking time off my job to try to go a couple times a week to a hospital facility for that.
Yeah, definitely having access to these kinds of things is a big challenge, right? Because a lot of the people who really, really need a lot of help have the most difficulty with accessing these things. So I appreciate you sharing all of that. Um, so Jesse, what about the evidence in terms of current treatment options? This is where I know it's so tricky with anytime I give a talk about hypermobile EDS and HSD, I always have to have a disclaimer, right? All the treatments I'm going to talk about are off-label because we literally have no unlabeled treatment for EDS and HSD. Um, what evidence is there for the things that, were just mentioned or the things that you think are most beneficial?
So one thing I will say is that, as Cassie mentioned, she's been using GLP-1 drugs. And we recently did a pretty large survey, about 2,700 people who have lipedema, and asking them if they're using GLP-1s and if those drugs are helping them. And it's a survey, so it's not a control trial. Strictly speaking, it is not evidence, but it is, 2,700 people, about 2/3 of them are using GLP-1 or GIP-1 drugs. So, tirzepatide or semaglutide. And almost all of them are seeing symptomatic relief of their lipedema symptoms. So we're seeing statistically significant improvements in mental health, physical health, and lipedema symptoms amongst the population of people using these drugs. So I think that is the one thing that is really encouraging, is that there does seem to be starting to be some pharmacological hints that we can sort of start to treat some of the symptoms in a way that's more holistic versus some of the other kind of treatments that are really, really going after symptoms, right? And not sort of the underlying causes of the disease. So otherwise, I'm not sure there's a lot of evidence. This is a funding issue, right? Like, these are treatments that are working. We hear a lot from patients that these are treatments that are working: the compression, the lymphatic drainage, the low impact exercise. Like, we have a lot of anecdotal evidence that these are super helpful and super important, but funding studies to actually interrogate them has been the big problem in the field, to really understand the benefits.
And I would like to add, on the treatments page that I did reference earlier, we do indicate where there are papers that exist that talk about these treatments, and we do also have a learning library called Legato, where we essentially pull every published paper that concerns anything to do with lipedema, so people can go explore for themselves. And what I would say for any patient, you can go on social media and there are way too many quick fixes being advertised these days. That's not the way that we need to approach this. We need evidence-based research showing that these things are working. And there are definitely studies out there for things like pneumatic compression, wearing compression. They're, not huge studies, but there are some studies that talk about these. And where those studies exist, we try to note them. But again, so much of what we have listed as treatment options come because patients are telling us what is working at reducing their symptoms. Clinicians are reporting on what they're seeing in their own patients. So a lot more funding needed to really look for these benefits. But as a person living with lipedema and managing it very well, many of these treatments have been life-changing for me in restoring my mobility and quality of life.
And some people might argue with me about this, but when we talk about evidence-based medicine, to me, all of that is evidence. It's just, there's a difference. Yeah, there's a difference between a double-blind, randomized, controlled trial versus a person trying something and saying that it works. We just have to factor that into consideration. And also we have to factor into consideration, is this something that has a lot of risk, or is it something that is not very risky? So wearing compression garments, like, I don't know that I really want like a ton of taxpayer dollars going to study that, because it's such an easy thing for a lot of people to do. Obviously there's cost associated, and I understand not everybody can do it. But I feel like we also need to be really mindful of the fact that all of this is information and it all could be useful. And I learned so much from my patients. I hear them talking about something, I tried this and that, and it helped. And so I kind of look at it and, well, this seems safe enough. And okay, maybe I'll try it. Maybe I'll offer it to another patient. I mean, we're just learning as we go. As Dr. Dacre Knight from UVA said the other day, you were at that conference, we're flying the plane as we're building it, right? So that's what we're all doing. I mean, if I sat around and waited until we had all these double-blind randomized controlled trials before I prescribed anything to my patients, they would all be suffering, and who knows how many of them might commit suicide or something in the meantime, which is horrible. So I never thought I would do this, but I prescribed tirzepatide to a lot of my patients. And it's not necessarily that we're looking for weight loss. We might be looking for control of inflammation and other symptoms. So we're microdosing. And when I say microdosing, I mean really microdosing. So I've had people send me messages, oh, I took, like, 2 milligrams or whatever. It's like, no, we start at like 0.2 or 0.35 milligrams often. So really microdosing. Anyway, I think that's all super, super great information. And then I do want to just ask, Jessie, can you talk briefly about surgery for lipedema?
Yeah. So, I mean, there's been a recent study out of Germany where they did a multi-center study about surgery for lipedema specifically. And the results of the study were encouraging enough that the German government is now covering lipedema surgeries for all stages of lipedema. So it is beneficial, and it does seem to have lasting benefits for symptoms for patients. So they've followed patients out. I think now they followed them out 12 years from their lipedema surgeries, and they're still reporting improvements in the level of their pain and their quality of life, and their overall lipedema surgery symptoms. So I think that surgery is, I mean, it's the only, at the moment, it is the treatment that has the most evidence behind it for, not the most evidence, but there is this study that has impacted policy, at least for lipedema treatment. But as Casey said, it's, again, a personal decision. Unlike microdosing tirzepatide or wearing compression garments, it is risky. So that is something to keep in mind as you're considering what your treatment options are. But yeah, people report long-term benefits from lipedema removal surgeries.
And I think for listeners to understand, when we say lipedema removal surgery, what we are specifically speaking about is liposuction that targets the lipedema affected areas. And so it is actual removal of that fibrotic nodular disease tissue from the body. It is not a cosmetic procedure. And while some people do experience some more cosmetic changes from it, it's not a pretty outcome. And that is something that people have to be aware of because you're trying to remove the diseased fat. You're not trying to give somebody a new shape. And removal of that diseased fat is where the benefit comes in. But that's what we're talking about when we say lipedema removal surgery.
That's really important. So people don't think, oh, I'm going to come out of this and look like XYZ. Having realistic expectations is so important. Before we wrap up, I want to talk about, of course, we need to talk about the Lipedema Foundation. Before we jump into that, I want to know from you, Jessie, where the research is today, if you happen to know anything promising coming up or where you see the field evolving over the next 5 to 10 years.
I mean, I think that we're in an exciting time. We just, at the foundation, we just closed out a grant giving period. So we're excited about the next 3 or 4 years of research that we're about to fund. We're really trying to understand some of the underlying mechanisms of lipedema. So what are the genetic factors? What are the proteins that are overexpressed or underexpressed in these cells? What is the communication network within the adipose tissue? How are the fat cells talking to the immune cells, and putting it all together for really understanding what the triggers are for lipedema and how the disease progresses, and really, really understanding the differences between sort of normal, quote unquote, healthy adipose tissue and the diseased adipose tissue that people with lipedema have. And then the other thing we're really working on is diagnosis. I mean, I think this is sort of the key to a lot of it, is really trying to see if we can find biomarkers, if we can diagnose lipedema from imaging data, and then move towards treatments and objective outcomes from treatments.
In terms of the Lipedema Foundation, Cassie, from a patient perspective, what should people know about the Lipedema Foundation?
Oh, there are so many things. So I will share very personally. I met Lipedema Foundation as a result of my diagnosis. Their brochure is the reason I have a diagnosis today. I walked away from a 24-year career at a very well-known financial technology company. My background is in business and human resource management. But as soon as I realized the state of lipedema and its impact on my body and millions of other people. And I won't just say women. While it does primarily impact women, it impacts men as well. And so there are millions of people impacted by this disease. I was when I first found out I had lipedema, I explored probably every single page of Lipedema Foundation's website to teach myself everything that I could know about it. And ultimately, my passion for learning about this led to me leaving that career to come work for Lipedema Foundation. So I cannot say enough about the resources that they make available. I've already mentioned the brochure. Our brochure is free for anyone that would like it. We will ship them to patients. We will ship them to clinicians. I heavily encourage patients to take those to their appointments. And I recommend for clinicians to have them available in their office to provide when they see a patient that they believe has this. That is one resource. Secondly, we really do a lot for clinicians to understand this. So we offer free in-service opportunities to train clinicians on this. All you have to do is let us know on our website, and we will schedule that. We have a professional learning manager who will have that talk with your practice or with you as a clinician. We have a clinician's guide to lipedema, which I mentioned earlier on the call, that essentially puts everything that a clinician would need to know about how to recognize it, how to diagnose it, how to code it in a medical chart, what referrals make the most sense for patients. We have so many resources available because we want for this to be recognized. And, there are resources for patients, there are resources for clinicians. And then obviously, as Jesse has mentioned, primarily what we do is fund research. And so we are studying every component of lipedema because we want to have clear diagnosis and treatment options and give people better quality of life.
That's incredible. I had no idea that this organization existed before now. So Jesse, what would you like to share about the Lipedema Foundation?
On the research side, we're also building sort of infrastructure for lifting research. We've funded a biobank, so we're collecting patient samples so that we can support larger studies to understand what's happening in the patient population. And then we're doing some of our own sort of infrastructure building projects, including a similar project to that I think is going on in the hypermobility community, sort of trying to find blood-based biomarkers using proteins and protein expression to see if we can move towards a more objective diagnostic.
Wow, that's so exciting. And what a great organization. And I'm so glad that I got the chance to chat with both of you today. As you may know, we like to end every episode with a hypermobility hack. I don't know if you each have a hack or if one of you has a hack, but if you have a hack, that would be great.
I do have a hack I would be happy to share. So I think for so many conditions like lipedema, all of the hypermobility spectrum disorders, we rely heavily on aids to help us be comfortable. And so my hack may seem very simple, but it's very impactful to me. I wear a heated vest nearly everywhere I go. It is like wearing a heating pad because often in these conditions, your body hurts and you have a very difficult time with temperature regulation. Within lipedema, we often see that the lipedema tissue is colder than the surrounding tissue. There are big temperature variations. I think that is also something that is seen often in hypermobility disorders. So I feel like wearing a heated vest is like having your own personal heating pad. And sometimes you just want to look normal. You don't want to look like you're having to have all of these aids and devices helping you to just maintain autonomic function on a daily basis. So I could have probably shared 100 hacks, but that is one I use every single day of my life.
That's interesting. And I don't know where you live, but I would love to know for people who just heard that and are like, great idea. I will definitely do that in the winter. But a lot of people, of course, are very heat intolerant also. So have you found anything that helps for cooling?
I have an ice roller that lives in my freezer as well as a neoprene cap that freezes, that is full of gel. And I literally use both of those things, particularly when I get migraines, which are frequent. I tend to run cold 99.9% of the time. And then the other 0.1% of the time, I am on fire. So I am almost always, I live in Richmond, Virginia on the East Coast. I am almost always cold. And then when I do flip to that hot, then I have the ice roller. All of those things I mentioned are things easily found on Amazon. They're just things that are part of my daily existence for managing temperature fluctuations.
And we'll add all of those to the Amazon store, the Bendy Bodies Amazon store. It's funny as you're saying this because I was just traveling with my husband and his temperature comfort zone is like this, and mine is like this. Like, I'm hot, I'm cold, I'm hot, I'm cold. And he's like, what are you talking about? He's just fine. Anyway, this has been such a great conversation and really just love chatting with both of you. Before we go, could you just share, we'll start with Jessie. Where can people learn more about you? And if you have any special projects or anything that you would like us to know about?
Yeah, you can find me on the Lipedema Foundation website, and then I think my contact information is there, and feel free to reach out if with any questions. We're really focused on getting people into the biobank. So if you are a clinician or a patient, reach out, and we will try to coordinate with you to bring you in and to collect your data and to have you be part of any future studies about lipedema.
And same as Jessie, lipedema.org is the homepage for our organization. We are active on most social media channels. So definitely Facebook, Instagram, LinkedIn, TikTok. You'll find us in all of those places. And we do have a newsletter that I highly recommend, regardless of if you are a patient, if you are a clinician, if you are a researcher, it is applicable to you, a caregiver, it is applicable to you. And we do share all of the latest research that is coming out. We are very frequently developing new free resources, and every resource that we have available is for free. They're available for download. Many of them we will also print and ship to you for free. And so those resources are so readily accessible, and we encourage you to follow our newsletter and website and social media channels, and you'll get all of that great information.
Well, we will definitely have that in the show notes, and you said the website, so people will definitely be checking that out. So, are you saying that if people want some brochures shipped to them, that you guys will cover the shipping?
You got it. That's exactly what I'm saying.
Because shipping has gotten really expensive.
You can literally order several of our resources. We will print and ship for free, including the clinician's guide. I will hold that up on the camera just for appearance.
People watching on YouTube. There's going to be people watching on YouTube that are going to say.
But
Yep.
If you're just listening on the podcast, you will find that on our website. We do have an easy ordering form, and you just tell us how many you need and where you want those shipped, and we will happily do so. We would love to see them in every clinician office, and we would love for patients to be uploading these resources in their patient portal and having these conversations with their doctors.
I feel like lipedema.org might be having a conference in the future.
Well, we are absolutely thrilled to be coming to the Ehlers-Danlos Society Global Learning Conference later this July and talking about lipedema as a comorbidity that often runs alongside. So that's probably the next place that folks can check us out. June is Lipedema Awareness Month as well. So we will be very actively sharing quite a bit. And I know for Ehlers-Danlos, your awareness month is in May, and we always tack on a little bit to that because there is so much overlap. So we look forward to all of our patient communities getting benefit from information over the next several months.
Yes, most definitely. And I look forward to meeting. Will both of you be there at the Global Learning Conference in Dallas? Because I will be there.
I will be there.
Okay, great. Yes, I will be presenting. I'm doing a presentation on Mast Cell Activation Syndrome on Friday night, and then I'm doing a workshop on pain on Saturday. So
I will plan to be at both of those.
Okay, fantastic. Thank you so much. It was great chatting with both of you. Thank you for taking the time to come on the Bendy Bodies podcast and share your stories and your expertise.
Thank you so much for having us, Dr. Bluestein. It was great to meet you.
It was such a pleasure.
Thank you so much for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at HypermobilityMD. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.